All right, welcome to HTI-1 Final Rule Overview number 1. My name is Chiara Matrosino with Kaufman and Associates, and I will be assisting with the logistical support for this Zoom session. Today's information session will be a presentation only. We will host a question and answer session on the final rule on Thursday, February 1st. We ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Mickey Tripathi.
Hello, sorry for the lag. Hi, everyone. I'm Mickey Tripathi, National Coordinator for Health IT. Thank you so much for joining our first information session on the HTI-1 final rule. We are very, very excited to be able to describe this to you. There's been a lot of hard work and a lot of industry feedback and stakeholder input that we've been very appreciative of as we've sort of given thoughtful consideration to all of the various comments that we received in the draft rule process and the comment period and the various stakeholder engagements that we've had that got us to a place now that we're able to issue the final rule, which we are very happy to be able to describe for you today. A couple of high-level thoughts, and I'm going to turn it over to Mike Lipinski, our head of regulatory affairs. First is, there are a number of elements in the rule. Everything from data standards to Fire API, some stuff on TEFCA, an important new or updated set of requirements related to AI-enabled tools, predictive decision support interventions, as they're called in the rules, which is an important step forward in our regulatory framework regarding the use of AI-enabled tools in healthcare delivery. As well as various aspects of the information blocking rules and the provisions there. All of those, we've tried very hard to do in this rule is start to bring those things together for us to be able to start to think about how do these different pieces fit together and mutually support each other and create synergies and complementary kinds of capabilities across those different types of policies to get us to the place that all of us want to be, which is an open industry ecosystem that removes barriers to information sharing that's authorized and allowed by applicable state and federal law in the best interest of the patient. So everything that you see in here related to certification, related to policy, related to network interoperability, API interoperability, public health, all of it is sort of pulling different levers in a way to help us all move forward in a way that provides greater coherence to interoperability and to everything that we're trying to accomplish as an industry on behalf of all stakeholders. So we're very excited about it, and we very much welcome further engagement with you as we begin to roll this out. The other thing I would just flag is, as I think we've said in a number of places, and as is posted on the unified agenda from last year, there is an HTI-2 coming. So we're hard at work at working on that. That also provides a complement to the set of final rules that we have here, and continues our forward march toward getting the kind of interoperability and the kind of health IT enablement across the ecosystem that that all of us want and that everyone living in the country deserves. So with that brief introduction, let me turn it over to the real meat of the program, Mike Lipinski, our head of regulatory affairs. Thank you so much.
All right, there we go. Thank you, Mickey. Happy New Year to everyone. Thanks for joining us today. We're going to jump right in so we can go to the next slide. So this is a disclaimer. Bottom line is we're going to do our best effort to present to you today exactly what is included in the final rule and what will eventually be in the Code of Federal Regulations. But sometimes we may make mistakes either on the slide or in speaking, and therefore this is a note to you that the official provisions are included in the final rule as well as in the CFR. So the disclaimer is a little bit different that if you were able to attend our annual meeting, and first, thank you for attending our annual meeting. But it is a little bit different in that we have some news since then, which is the rule is on display at the Office of the Federal Register, which means it's available for public inspection. It's a PDF document. I believe it's about 804 pages, or exactly 804 pages. And it will publish, as you see here on your screen, on January 9th, which means the effective date of the provisions of the rule will be February 8th, I believe, based on the 31 days, because it's a 30-day delayed effective date, and there's 31 days in January. And we'll talk a little more about what that means impact-wise at the very end of the presentation. We talk about some key dates as well as resources. Okay, so let's jump to the next slide. So why do we do these rulemakings, and particularly this rulemaking? First, I want to point you, besides what's on the slide here, I want to point you to the rule itself. There's something that started in the federal government. I can't pinpoint how long ago it was, but now every rule contains essentially an executive summary. And in that executive summary, one of the sections, so the executive summary is a summary of all the proposals and final policies in this case for a final rule, but also why we're doing it. So there's a purpose of action section. And I highly encourage you to read that. If you don't want to read all 804 pages, at least read the executive summary, because we'll give you a high level of why we're doing it, what we think it will accomplish with this rule, as well as summaries of all the final policies in the rule. But again, generally speaking, we are trying to implement statutory authorities. So Cures Act gave us some very specific statutory authorities, which this rule is either implementing for the first time when we're talking about the EHR reporting program, or is building on prior regulatory provisions that were, for example, included in the Cures Act final rule. So that goes to APIs. And then the reasonable and necessary activities are essentially the exceptions to information blocking. So we did that in the Cures Act final rule, but it is an ongoing process in terms of identifying potentially new reasonable and necessary activities that would not constitute information blocking, because as we all know, the health IT landscape and the health landscape itself is ever changing. And so we want to be cognizant of that in regards to how we interpret and implement the information blocking provisions. And then there's each administration, and it also crosses over administration's executive orders that various rules can help support. And so this on your screen here, you see, and we talk about this more in depth in the purpose section of the rule, as well as under each of the provisions in which there is some alignment in terms of to implementing the executive orders. So here you have obviously the data-driven response to COVID, and in future, any future public health emergencies. I could go on and on about how info blocking even played, could have played a role or did play a role in terms of how, that data was shared. For example, test results related to COVID, positive tests, things of that nature that could have been shared and could have been helpful during the pandemic and so forth. And obviously, a lot of our other proposals, including which my colleague Jeff Smith will talk about, the predictive decision support, the DSI decision support interventions criterion, that helps to support Executive Order 14.110, and he'll talk more about that. And then same with the USCDI and that one in terms of addressing racial inequalities and other inequalities in healthcare, as well as underserved communities. And then the last on your side, on your screen, again, using authorities from the HITECH Act, as well as just in generally, and that includes the certification program, particularly advancing interoperability. So interoperability has been a focus for us, obviously, but also for Congress. If you look at the history of the laws that they have passed, they have consistently focused on interoperability, starting with the HITECH Act all the way to the Cures Act, giving us a definition of interoperability that we are trying to implement through our various regulatory activities. So I will move on to the next slide. So what are we talking about? What's in the final rule and what are we talking about today? This is essentially a short agenda to highlight all the main parts of the rule and today's presentation. The first four on your screen focus on the certification program. So you're either using certified health IT or you're having a product tested and certified under the program in terms of these four having implications for you. The last one is information blocking, which is broader than the certification program, does not focus or rely on certified health IT, while there are certain exceptions that try to leverage health IT to improve interoperability. The program or the provisions themselves are much broader and actually affect a broader group of stakeholders than just those participating in programs that require certified health IT or having products certified under the program. Moving on to the next slide. So the first topic, the additionalist approach to our certification program. We can move on to the next slide and we'll jump into this. So we propose to not have an addition naming based on years. So right now, until this rule becomes effective, it's still the 2015 edition of certification criteria. We talked in the rule, lengthily in the proposed rule, as well as reciting again in the final rule, about our approach to naming additions, why there were drawbacks to the way we had, even though we thought they were good approaches at the time, there were drawbacks to those approaches in terms of, for example, people assuming that because it was 2015 edition, it only include functionality from 2015 or standards from 2015, which actually we updated with the cures rule in 2020, but kept the name 2015 edition. So what we've gone to now is just going to be the ONC Health IT certification criteria. And we're going to talk a little bit more about the value in that with the next couple slides too. Obviously, their benefits are listed on the screen here, but we'll get in more about how compliance is and why that will be helpful to you, to users of Health IT, certified Health IT. Moving to the next slide. Okay, so what we did to complement that proposal of changing the name of our certification criteria away from additions and just an additionalist approach of just ONC Health IT certification criteria, we set timelines for essentially when the functionality and the standards would be applicable or in use. So for lack of better terms, we've used expiration dates, and then we've obviously established applicable timelines for each of the standards. We'll talk a little bit about some of those in the presentation today, what those timelines are, and then how we're going to go about so one of the ways we'll go about this, for those of you who are familiar with this, the Certified Health IT Products List, affectionately known as the CHAPL, lists all products that are certified. And what they will do is they'll be able to have functionality that you'll know what standards a product was certified to. So whether that product or Health IT has been certified to the new standards or is still certified to the current standards that are still viable under the program, but not the newer version yet. So there will be ways through that functionality to understand what your product has been certified to, but ultimately you'll still know whether your product is certified under the program as well. Moving on to the next slide. So compliance. So this is really a focus for customers under the program of customers of certified health IT. So we're asking or requiring developers to do now with a final rule is some certain forms of compliance, which is if they've had a product previously certified to a criterion that's revised, so we have a definition of revised, they then have to update within a period of time to the new standards that have been adopted for that criterion. And this includes if there's any new functionality added as well, not just a standard. When we propose this, we propose it two different ways. It's part of the criterion itself, but also as what are these conditions of certification and maintenance that now exist after the passage of the Cures Act. And one of the maintenance requirements now is essentially a timeliness requirement for developers in terms of providing it to their customers. So they have to update, provide it, and then we give the timeline. We did get a lot of feedback on our timeliness approach in that it could be confusing because it had generalized provisions about, unless otherwise stated in this part, you had this much time. So then a user or a developer would have to go figure out, well, did we state somewhere else that the timeline was different, and what is the timeline, and how does that compare to this, what you're proposing as an overall timeline? So what we've actually done in the final rule is anything that has a timeline, it's specifically stated. So for a new criteria with a new standard, we've set timelines, and like I mentioned earlier, we're going to talk about some of those, but hopefully this will provide the clarity that commenters and developers were seeking in regards to a final policy. Moving on to the next slide. So let's talk about some of those standards and functionality updates and the timelines that go with them. So next slide. So the big ones are obviously US CDI. So version 3 becomes the baseline, and we'll talk a little more about what that means. This is just an overview slide. There are standards that are associated with the US CDI in terms of being able to make that data available via the functionalities. So whether it's an API functionality or a view, download, and transmit, such as for lack of a better term, a patient portal, or a summary care record that's going to be shared, which could be via CCDA, at least from a certified product, it would be. So on your left there, you see all the key standards, and I just mentioned a couple of those. For FHIR, you have the core standard and then the CCDA one. And then they're vocabulary code sets, and we set minimum code set standards under our program. And those are some of the standards, and we'll talk about which version we've set as the minimum code set. But there is a process in which you can use under the program code set standards beyond the minimum, because we know how often they change. Some are as often as monthly, quarterly. So you can use those as long as we don't identify those standards as adversely affecting interoperability, in which case you would not be able to use the next version, but we've never done that. And then there's another process we'll talk about a little bit called SVAP, which allows developers to move to the next standard that we identify, next version of a standard already adopted. And that's going to be important when you're talking about, like, for example, US CDI. Other revised criteria that have been affected, so that's on your right of your screen, so the electronic case reporting, we'll talk about that one specifically. My colleague Jeff's going to talk about what is now decision support intervention criterion. And then the standard API, I'll talk a little bit about that, and pretty much all the ones you generally see on the screen we'll talk about. We're not going to talk about the patient demographics one so much. It was more that update there was alignment with the codes that are within the US CDI for gender and sex. And then the transition of care one was also had an update related to obviously US CDI and the CCDA companion guides. Moving on to the next slide. So US CDI, it was, I won't go into the full history of, what it started out as, which, it was a set of data that needed to be available for exchange, for example, and again, a CCDA summary care record is part of what was affectionately known as meaningful use under the EHR reporting program, then became the common clinical data set. And then now we are the stewards of the US CDI standard, which it is now. And it's and we started off with version 1. We're actually at version 5 had already went out for public comment. Comment period closed last year on that. So we're looking reconciling those comments and considering those comments and putting out a final version of US CDI 5. But for the purposes of certification, the new baseline will be version 3. And I mentioned that the concept of SVAP, which is a voluntary process for adopting new versions of standards that we've identified. So right now we have US CDI version 2 available under the SVAP process, and we would probably be considering more recent versions of US CDI for SVAP as well in the future. So we move on to the next slide. With that history and understanding, you can see what US CDI is. So this is for products, again, they get certified, a compliance requirement. So this is separate from the actual adoption, the steward we'll call it an SDO process, of the standard itself, which can be used voluntarily for other reasons or other methods of interoperability. But for purposes of certification of health IT under the program, this is the version that we've set all products that are getting certified to criteria that incorporate USCDI version 3 will have to move to this baseline of data for being available for access and exchange in certain circumstances. Next slide, please. Just a little more about USCDI, including the time frame. So I want to point you to that in particular. So, this was we took comments, we made some changes with the timelines. This is one of them. So they have until January 1st of 2026. So they'll have all of this year and next year to update and provide products certified to criteria that reference USCDI to their customers, developers, that is. And again, as I was mentioning, that our chapel will identify what products have, if they're still certified to just USCDI version 1, which is the current baseline, or if they've already moved with their products to be certified to USCDI 3. But all products will have to move by January 1st to USCDI version 3, or they no longer will be considered certified. And these are the criteria, as I was talking about. So, those ones that are reference USCDI, these are the criteria, the references, which are the important ones in terms of, like I said, again, access and exchange. We will move on to the next slide. Take a look at the clock. So minimum standards code sets. The one thing we didn't do here compared to the proposed rule is update to a more recent version. So what you're seeing on is the versions that we proposed. Obviously, when it came to core and even to the companion guide for CCDA, we updated to a version more recent than the one we proposed to ensure interoperability. There were errors, ambiguities that needed to be corrected in the versions that we proposed, so there was full alignment with USCDI, for example. And so, but here we stuck with the versions we proposed. And as I said, that you can still use a newer version as long as that version has been identified by us, HHS, as adversely affecting interoperability, which we are not done. So these are the new baseline, but you can use a version. And this you don't have to go. So your uniqueness between code sets and the other standards, the code sets don't go through SFAP to be approved. So you can actually just use those and not have to, under the program, not wait till they are approved through the SFAP process. Moving on to the next slide. So this is a big one, not just in terms of moving to the new standard and making more data available through APIs, the read-only APIs under the program, but also from a privacy and security perspective and from a transparency perspective, which the transparency piece, I think, will help further improve the access to EHI data, particularly the USCDI in this case. So moving past the standards part, we did standardize and use a standard-based approach for authentication authorization, token introspection as well, and again using the Smart App launch IGV2. The other key point is the revocation. So we've clarified that in which time the authorization is granted with the token has to, for when the revocation has to occur of the within the request timeframe. So before that wasn't specified under regulation. So we've done that. I think this will improve both consistency across all developers in the program, but also obviously security of EHI. And then the key one, I think, also is at the last bullet point here. So we're standardizing the URL publication approach. So this should make it easier for apps who want to connect to the API to find that information they need and be able to do that. And this is directly in response to a lot of feedback we received since publication of this requirement to publish the URL in the Cures Act final rule. Moving on to the next slide. So electronic case reporting. So this is in line with our proposal. Again, standards-based approach here, and giving optionality to the developers from either the CCDA perspective or the fire, hoping eventually getting to the fire approach, knowing, but this is a recognition of the current landscape as we discussed in the proposal rule and based on the comments we received. Moving on to the next slide. So patient requested restrictions one, we put out a robust proposal here, offering various alternatives and approaches to address this issue. I think as we anticipated, we received a lot of feedback expressing concerns about how that would, with the technology where it is today, the ability, for example, to capture this information in terms of and apply those restrictions to the data, and particularly as that data is accessed and shared. I do want to know we do have a functionality under certification now, 2 criteria about security tagging that using summer care records, the CCDA, and using the DS4P standard. So those still exist for sending and receiving with CCDAs, summer care records. But our approach in this final rule, we still wanted to acknowledge, as we discussed in the proposed rule, a patient's right to request restrictions, and we wanted to somehow support that through certified health IT, and therefore we're giving some flexibility to developers, but they still must provide an internet-based method. So the flexibility is in that. It's not a specified method that we're saying, but they need to provide an internet-based method when they get if they're getting certified to, what you see here is just the CFR specification, but what we're talking about is the view, download, or transmit criterion, which is E1, 170.315 E1. Also, as I referenced, like your patient portal functionality. So in that, if a developer is getting certified to that, they need to find a way, use their creativity and flexibility to provide a way for patients to express their rights related to their EHI in terms of what they would like restricted for accesses and sharing disclosures of that data. We can move to the next slide. And at this point, I'm going to turn it over to Jeff Smith, who is our Deputy Director for the Certification and Testing Division in the Office of Technology. Jeff?
All right. Thanks, Mike. If you could go to the next slide, please. Okay. All right. Well, I'm going to caveat this and the next sections, and actually we've got 3 more sections to go through, and I just want to highlight that we will have deeper dives on the DSI section, the information blocking section, and the insights section through upcoming webinars. So the DSI section is going to be January 17th. The insights webinar is going to be on February the 8th. And then the information blocking webinar is going to be on January the 25th. So just important to note that we're going to give you a taste really of what the requirements are over the next 20 minutes or so. And then there's going to be some deep dives that go much further into the subject matter and the requirements. So at a really high level, I think it's important to start at kind of the top and acknowledge that ONC has been looking at the issue related to AI in healthcare alongside other federal partners for a number of years now. On the left, you'll see a graphic that was part of a really, I think, foundational report by GAO that looked at kind of a landscape of how artificial intelligence was being used both in clinical care as well as through administrative applications. And so this really set, I think, an important framing for how we thought about artificial intelligence and machine learning applications and software within the broader healthcare context of, so as part of this, we engaged in a several months, what turned into a couple of years long exploration of this space. And we documented things that we found along the way through a series of blogs. And you can see that the first one published in June of 2022, but we actually spent several months prior to that kind of looking at this space more closely and quite generally with a lot of enthusiasm and a lot of optimism. But we did find that there were some challenges, and I think these challenges on the right here are all very well documented in the literature. It would not surprise, I think, most people who've been paying attention to this space that the unparalleled opportunity to improve patient care is also somewhat hampered by the new level of scale that patient harm could befall users and patients if certain aspects of this technology are not taken care of and if certain facets of its use are not well documented. If we can go to the next slide, please. Okay, so after this exploration of the space and after we understood some of the challenges and some of the opportunities, we obviously came to a point in time where we thought about how do we use the ONC certification program to positively impact this space. And I would say that a guiding principle of ours was how do we optimize the use of high quality predictive algorithms in healthcare? And that is really important in two ways. How do we support the proliferation of algorithms? And then how do we ensure that the algorithms that get proliferated are of sufficiently high quality to be on the market? So ONC has, through its certification program, a rather interesting and I would say important, albeit narrow, way to influence this space. And that was through our clinical decision support intervention, or clinical decision support rather, certification criterion. And this CDS criterion has been on the books since 2012. And so it was really through this criterion that we thought we could update the criterion and then expand it to be more inclusive of the types of modern predictive algorithms that we're seeing being used to support decision-making. So in the HTI-1 final rule, we did revise the CDS criterion, and we built on top of this and built around this to what is now the DSI, or Decision Support Intervention Certification Criterion. A couple important changes from the proposal. I think we streamlined and simplified requirements for all health IT modules. We had proposed an attestation statement, which really could have had the positive benefit of ensuring that certain requirements were conditional only to those developers that enabled or interfaced with predictive DSIs and didn't compel developers to enable or interface with predictive DSIs. But we also saw that as creating the potential for a two-tiered system when it came to user experience. And so we established a set of requirements and capabilities that will be universal across health IT modules certified to B11, which is where the DSI criterion will sit in the Code of Federal Regulations. But we also maintained the conditional requirements that will pertain to predictive DSIs. So it's important to note that developers of certified health IT that will want to have modules certified to DSI are not going to be compelled to author or supply or develop predictive DSIs on their own. But we will have specific requirements for predictive DSIs that are supplied by certified health IT developers. And that gets to that third bullet point there on the left, which is we did narrow the scope of impacted predictive DSIs from what was proposed. We did propose a scope that include enabled or interfaced with. And we constrained that to say that the requirements for our program will only pertain to those predictive DSIs that are supplied by the developer of certified health IT as part of its health IT module. And we do go into some depth as to what supplied by means, but just know that kind of at a layman's level, and we will talk more about this in the DSI specific presentation, supplied by means that the product is part of a developer's offering to its customers. The certified developer knowingly makes this available to customers, and customers knowingly know that it's coming from their provider, or from their certified developer. So a couple of other high points, and then we'll move on. We did finalize the predictive decision support intervention definition more or less as proposed. We tried to clean it up just a little bit, but the scope is pretty much as it was proposed. We did have some requirements for health IT modules to enable users to provide feedback data, and we scoped that to just evidence-based DSIs and to make sure that that feedback data is exportable for quality improvement purposes and other research purposes. We finalized that health IT modules must enable users to select both evidence-based and predictive DSIs. And we felt this is important, like I said, to ensure that there isn't a two-tiered system when it comes to user experience. Much in the way that today users have the ability to select evidence-based DSIs, we think it's important that users will have the ability to select predictive DSIs, either those that are supplied by their developer of certified health IT, those that are developed in-house, or those that are developed by a third party or what we refer to as an other party in the final rule. We also require that modules enable users to access complete and up-to-date source attribute information for evidence-based and predictive DSIs, as well as provide users the ability to record, change, and access source attributes for evidence-based and predictive DSIs. Of course, another big piece of what we proposed related to risk management, and we did finalize requirements for risk management and that those practices be applied to predictive DSIs that are supplied by the health IT developer. And then we established a new assurances maintenance of certification requirement to ensure that developers that supply predictive DSIs as part of their health IT product review regularly and update as necessary information on an ongoing basis. We know that the source attribute information that we proposed, both by design and by happenstance, does change over time. And so we wanted to make sure that there were programmatic requirements to ensure that information, when it needed to be updated, was updated. Next slide, please. Okay, so I'll have to go through the next few slides quickly so we can stay on time, but I think it's important to note here that we understand that the certification criterion exists within a larger ecosystem of policy objectives. There is, of course, the functionality, and that's what the developers are enabling through conformance to the certification criterion. But there are several really big picture policy objectives that we think we can help positively impact. I think first and foremost, we're hoping to improve transparency regarding how predictive DSIs are designed, developed, trained, evaluated, and should be used. We also think that this transparency is a first step towards improving and enhancing trustworthiness. And this really gets to the proliferation of high quality algorithms. If users can trust that the decision support that it provides is accurate, then they'll use it more. We also think that the source attributes that we have finalized will really foster an information ecosystem that will be necessary to help healthcare organizations and users determine whether these predictive DSIs are fair, appropriate, valid, effective, and safe. And I think that the FAVES framework that we describe in the proposed rule and the final rule is a really important North Star for us. And we think that all of the source attributes and the risk management requirements are designed to align with this notion of how to determine whether the technology is fair, appropriate, valid, effective, and safe. And then last but not least, we think that our requirements will advance health equity by design by addressing bias and health disparities that may be propagated through predictive DSIs, and really expand the use of these technologies in safer, more appropriate, and more equitable ways. Next slide, please. Okay, so last slide on DSI. Again, the deeper dive is going to be on the 17th of this month, but I think it's also important to note here that our policies, our requirements do not exist in a vacuum. What is emerging out of HHS writ large is a mosaic. I think obviously the FDA has 700 plus products that they've certified for medical devices that have artificial intelligence capabilities or aspects to it. And the Office of Civil Rights has a proposed rule around the use of these technologies and ensuring that they're not used in ways that are discriminatory. And so I think over time, you'll see the logos on this slide start to proliferate. I'll note that there obviously was an executive order released at the end of last year that requires HHS to develop a strategy. There was also a meeting and a list of committed organizations who have said that they are going to willingly commit to following certain standards, and the FAVES framework is called out explicitly in those commitments. So just know that there's a lot of work going on behind the scenes. There has been going on behind the scenes, especially with the FDA and OCR, but with others as well, to ensure that our requirements are complementary and aligned. And I will say we did opine quite a bit in the final rule around how the FDA and ONC work together. So for those of you who have that question, I would invite you to visit the DSI section of the final rule. Okay, next slide, please. Okay, on to the insights, condition and maintenance of certification requirements portion. I will remind you that we've got a deep dive on this February 8th. So please bear with me as we try to get through these slides in time for information blocking. So next slide, please. All right. So as mentioned earlier, that the FDA or that the HTI-1 rule was in part done to implement lingering aspects of the 21st Century Cures Act. The EHR reporting program, I think, was probably one of the most prominent pieces that were yet to be put in place. And of course, ONC has been telegraphing for a number of years that this was going to be coming. So to say that this piece of the puzzle was roughly 8 years in the making would not necessarily be an understatement. But we did start in earnest over 4 years ago in trying to develop a policy and set of measures that would fulfill the statutory requirement for this program. So next slide, please. Here you can see just an overview of the steps that we did take, really going back to the end of 2020 through release of the HTI-1 proposal and finalization. We had several open comment periods, one dedicated specifically to the report that Urban Institute and Health Tech Solutions put out, as well as open comments around recommendations from a high-tech task force. So we had a lot of public input on the contours of this program, and we took the public feedback and we supplemented that with additional expert consultation and research to come up with the measures that we proposed. And then ultimately, we got a set of measures based on public feedback through the HTI-1 proposed rule. Next slide, please. And here you can see those measures. So we've got 4 broad categories. As we noted in the proposal and in the final, we decided to focus on interoperability measures first. The Cures Act actually laid out several other areas of measurement, and we decided to start with interoperability because we think that that's an important area for us to focus on initially. And we've got here 9 measures related to these, sorry, not 9. Yes, actually 9 measures related to these 4 categories. And it's important to note here that, again, we were very deliberate in thinking through measures that would be specific to policy areas that we all care about, including individual access to EHI, clinical care information exchange, public health information exchange, and then standards adoption and conformance. And we do think that, true to the name, kind of renaming from the EHR reporting program to the insights condition, we do think that these measures over time will give us really important pictures into the state of interoperability across our nation. So here are the measures. If we can go to the next slide, please. This and the following slide will provide a little bit of information on kind of the nuances that we'll go much more in depth on during the dedicated webinar on the insights condition. But I think it's important to note that the Cures Act statutorily required that we think about measures that would not unduly burden small and startup developers. And so we did create carve-outs, or we did create the ability for developers who did not meet a certain threshold of customers to be able to attest that they did not meet those thresholds, and then would be able to, until they met the thresholds, they would be able to avoid having to report these measures. You can see here also, if you're a developer with a module that is not certified to any of the criteria that were listed on the previous slide, you also would not have to engage in the program. And I will note here, the last bullet here on developers, we finalized that developers of Certified Health IT will provide a percentage of total customers that are represented in the data that they provide. And this was meant to address comments that we received in terms of the feasibility of reporting across all customers within a developer's client base. So an important degree of flexibility there. Next slide, please. Okay, now in order to try and soften the blow, if you will, around the development burden that would come along with implementing this program, and also just being cognizant that some of these measures we think are more easily reportable earlier than later, we've established a kind of staggered way for developers to report these measures. So a few kind of caveats. These measures will be reported across products and across versions. And we think that will have an important and helpful way of aggregating this data across clients for developers. And let me just hop to the next slide so I can talk a little bit about the reporting cadence and frequency. So this is the kind of generic reporting frequency that we've established in HTI-1. In a subsequent slide, we've got the actual years assigned to this, but I think it's important to know that, again, what we tried to do here is we tried to stagger the data collection period and the data submission period, and then we even broke up the specific measures into different years. And so we're going to have kind of a three-staged reporting paradigm for the insights condition. If you could go to the next slide, please. And so as you can see here, the different measures will be reported at different years. I think there's actually, if you go to the next slide, we've got a slightly better visual for this. All right, yeah, perfect. So this is going to be how we space and pace, to use a favorite phrase of Steve Posnack's. This is how we're going to space and pace the reporting of the insights condition. I think this is doesn't look a little complicated at the surface, but I think is going to have demonstrable impacts in terms of how developers need to comply with this program. And hopefully we'll make it to where we can start to get information on a rolling basis that over time will start to really fill in this picture of interoperability across the nation. So you can see here, beginning calendar year 2026, developers will need to start collecting information on year one measures. And then they will actually have until July 2027 to submit information on that. And so you can see on a rolling basis, we're going to kind of implement this program and have developers submit data across those measures. Next slide, please. Okay, with that, I'm going to hand the mic back over to Mike. And
all right, there it is.
There he is.
Thank you, Jeff. So at this point, I'm going to run quickly through. We have about 10 minutes left. I'm going to run quickly through the information blocking final policies, then touch a little bit on our resources. Again, emphasizing when the next webinars are coming up, and those will be information in the slide, but also on our website, and just maybe a couple other final points to mention. So before I jump in on this one, we gave a presentation on information blocking at the annual meeting. And again, thank you if you were able to attend that. The one that we're going to do later, so we are doing a specific information blocking presentation. It'll be an hour long. It will be focused just on this rule. So the one at the annual meeting talked about this rule, talked about the provider disincentives rule, and I want to pause it there and say thank you to everyone who's in attendance today and commented on that rule. We are now in a process of considering those comments, reviewing, reading them, and then we'll deliberate on both the comments and what should be the final policy, including any alternative proposals we had in that rule. And while we didn't identify, I know this is a little bit of a tangent, on the unified agenda, a target date for the final rule, I can tell you, just like, as Mickey mentioned, the HTI-2 rule, we are focused on that rule simultaneously and hope to get it out in a reasonable period of time, but definitely in this year. I wish I could say more on the target date. So let's jump in on this particular part of this presentation and go over real high level what we proposed and where we ended up on the final policy. And again, we'll have another presentation on that. And I think I forgot to mention, didn't finish my thought. We also talked about OIG CMP rule at the annual meeting. So again, the presentation coming up on info blocking January 25th will be just on this rule. So we'll be able to go into depth on everything, including a little discussion of the comments we received, and I suspect have some time for questions as well. So this was in the rule, final rule, and in the proposed rule. So the one thing that is different, where you see new, the TEFCA manner exception, it was actually a condition under what was called a content and manner exception. Now going to finalize as the manner exception, but now it's a separate own exception. And actually we've created a new subpart D from regulatory speak about just on TEFCA. So any reasonable necessary activities that we identify as not information blocking, so an exception, they'll be housed in the regulation under subpart D. All right, next slide, please. So these are the definitions. I want to point out something real quick because I forgot to do this at the annual meeting and I almost forgot to do it again. So in the version on display right now, I think it's what page? Okay, around about 519 or 520 is where we start information blocking enhancement, it's called. And there's a section on general comments. And I highly encourage you to look at that if you're covered, if you're an actor under the information blocking regulations, or if not, if you're someone, for example, a patient, because we talk there about the use of the exceptions and how you can use exceptions together, for lack of a better term, but a term we use in the preamble, stacking exceptions. So it would be where, for example, the example we give in the rule is the use of the privacy exception. The privacy exception can be used in multiple ways. For example, a precondition not satisfied is one of the sub exceptions under there. Or another one is where a patient requests that their information not be shared. And we talk about how those particular sub exceptions of the privacy exception can be used to restrict the sharing of certain EHI, and then how under, for example, the infeasibility exception, the segmentation condition can be used in conjunction with that in terms of not sharing information and not being an information blocker because you meet an exception or two exceptions in this case. So I highly encourage you to take a look at that as well, besides what we actually proposed and finalized. So as far as definitions go, really, it is still the same categories of activities or actions that that we have excluded from the term offer and thus not part of the health IT developer certified health IT definition. What we did was massage a lot of language, and like I said, we can talk about that a little more in the next presentation on the 25th. Bottom line, same definition with some just wording tweaks and same activities that are excluded from offer. The developer, health IT developer of certified health IT also revised, tweaked a bit for the self-developer part, which essentially is that they don't offer it to others. That clarity, again, another language tweak. And then the information blocking definition itself has been updated because of the content, the provision we proposed and removed the provision that limited the definition to essentially the EHI limitation that we have for USCDI because that date had passed. The other minor tweak there is because we created a new subpart for TEFCA, we had to reference that in the definition itself as well. Moving on to the next slide, we're going to jump into the exceptions and we're going to move through them quickly. Okay, uncontrollable events, we actually tweaked the language again here compared to what we proposed. We were playing around with this due to, because of. We tried to make it as clear as possible. So essentially you get the benefit of this condition under this exception if it's because of one of those events, and there's a whole list of uncontrollable events, has a negative impact upon your ability to provide access, exchange, or use. That is what needs to be demonstrated by the actor to have the benefit of this condition under the feasibility exception. The other one, third party seeking modification use condition. Again, some wording tweaks. We removed some language from the reg text that was already clear in the preamble and may have caused some confusion in the reg text. I think we spent most of our time in the final rule clarifying either misunderstandings or what maybe some commenters thought were ambiguities as to when this condition could be used by an actor. So again, it is only in these very specific circumstances where you're talking about a business associate and a healthcare provider, and it's another party that isn't a business associate that the healthcare provider said could have that type of functionality, which is to modify, which is to be able to modify the record. And we discussed what that is: create, delete the record, for example. Those are just two examples of activities would fall under that modification use. So again, this is pretty much as proposed, finalized. Moving on to the next slide. Manner exception exhausted. This one, again, as finalized as proposed, with clarity about the term similarly situated in reg text specifically. So I think we, you know, what our intent and based on the comments was there was a little bit of misalignment or misunderstanding or concern about when or how a potential actor could maybe misuse the term similarly situated. So we pulled from the preamble and put that in reg text. The proposed rule preamble in terms of what would constitute similarly situated and what would not. So that goes to whether, provider healthcare size that isn't a basis for example, it isn't a basis between a patient and a provider. You couldn't argue, well, they're not similarly situated. That wouldn't be permissible under our interpretation of similarly situated. So, and then obviously if it was for competitive reasons, that isn't a basis to argue they're not similarly situated. So I think generally, and the other major, I should note real quickly, is we proposed that it could be all the manners under the content and manner condition, alternative manner, which would have been through certified health IT, through one of the standards-based way, and then finally in a machine readable format as the third option. So what we did is it had to be in the final policy is either via CERTA or via certified health IT or standards-based approach. And then the other way is still, so it's two options, two ways that have to be offered comparative to all three was our going out position in the proposed rule. We will move to the next slide. This one was a cleanup as similar to the information blocking definition. So we removed the content condition because it's EHI as defined in reg text now. It wasn't limited for that period of time to just data elements represented by the USCDI version 1. And then we said redesignation of some of the paragraphs. So more procedural than anything else when it came to the manner exception. And moving on to the last one, which is the TEFCA manner exception. So this is a new exception in a new subpart, as I mentioned. The bottom line big changes here compared to what we were proposed are one that we are applying are applying. So it was a understanding of the as you know, TEFCA was still somewhat in development processes and the common agreement, and in terms of how it would apply to various actors, say, for example, one QHIN and another QHIN, or even two in the same QHIN and they're exchanging, in terms of where the no fees would apply and so forth by terms of those agreements, the framework agreements, and the common agreement itself, which only applied, to the QHINs on the fees piece. So I think it was a bit of a, misalignment, I will say, with our proposal. And we have applied back in the fees and licensing exception based on feedback and the better understanding of all parties that would be subject, potentially being able to use this, subject to and being able to use this new manner exception, TEFCA manner exception. And lastly, also a big change based on comments that we got was if it's a request for use of access exchange or use of via an API standard using FHIR, essentially, bottom line, FHIR under a program, the standards or a SVAP version of that standard, then you can't use this particular exception. Even if the other conditions, as you see on the screen, are met, that they're both part of TEFCA, and that TEFCA could support it either via technically or the agreements between the two parties, the requester and the actor. If they make an API request, this cannot be used as currently finalized. I think we can move to the next slide. I'll get us through information blocking. I know we're at time. Just want to share this slide. It's a slide, next slide, that is available on our website as a fact sheet. It's a resource. The one point I would make is so this sets, the various timelines for compliance. We've talked about them, the USCDI, we talked about insights. It identifies some of the other ones. The key point about information blocking, come February 8th, then the rule is effective. Those exceptions are available that date. So then they are available to any actor under the program on that date. There isn't a lag beyond the delayed effective date for use of those exceptions. So those exceptions become available come February 8th when the rule is effective. Wanted to emphasize that point when we talked about these key dates. I don't think that's listed on here. Moving to this is more focused on the program. Move to the next slide. So again, as I mentioned, the fact sheets, you can find all this on healthit.gov. You have the link right there, and these slides are going to be made available. And then lastly, I'm going to talk on the last slide. Next slide is the webinars we've been referencing throughout this presentation. So next one up is decision support interventions, and then we'll have the information blocking one, and then an overview where there'll be an opportunity for Q&A, where most of the time will actually be spent on Q&A. I would think almost at least a huge, I don't want to give you a exact percentage right now, but our intent is to give a lot of time in that webinar to Q&A. And then insights. So also talked about today, but we'll have a session, a whole hour session just on insights as well. And I think that takes us to our last slide and includes, thank you for putting in a little extra time today with us to hear the entire presentation, and hope you found it valuable to you. And we'll be back to talk to you more. Thanks again. Bye for now.